All right, welcome everybody to SEVA VentRounds. It's February 6th, really fast things go by. Let's get started. We have a very interesting case, well, actually a couple of cases that were donated by Enrique Pacheco from University of South Florida. So we will take a look at those in a second. All righty. Remember, so the title for today is What Do I Treat First? And I think that this is a good example of when so many things are wrong. So no endorsements of any mode, manufacturer, or company are done by us. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles, and those are my disclosures. And Rob Chatburn, right there by the pagoda, you can see them on the video. Thank you, Rob, for joining us. And these are his conflicts of interest. Keep your microphone muted just for the health of this recording. However, if you want to comment, either put it on the chat or you can unmute yourself at that time. And that really helps for us to be able to keep nice recordings of this for posterity. There are CRCs and CMEs. If you're in the clinic, there are CMEs. And if you're anywhere in the US and you're a respiratory therapy, you can get a CRCE. There's a chat, you put there your name and then just put, there's going to be an evaluation that will be posted, fill it up, and that's it. You get your CRCE. So as always, we start with a SEVA teaching moment. And I thought that even though you're going to see several other things on these images, that we would start with cycle synchrony. And cycle synchrony refers to the time where the respiratory effort has finished and but the ventilator continues to deliver inspiration. So in the example that you have here that we're calling late, you can see that the effort from the patient has finished, and actually the flow is flat here, meaning that there is no flow occurring. All the inspiratory effort has occurred, and actually, in retrospect, you can see that there is an increase on the pressure, and then eventually the valve opens up, so it's cycled by time, and so this is a breath that it's late cycled, and so the characteristics is this period during flow in which you see no flow and a raise in pressure. If you were on volume control, you may see this increase in pressure at the end of the breath as the expiratory muscles activate or the chest wall relaxes. An early early cycle, you can see that the breath stands here, but the ventilator cycles, inspiration ends earlier than what the patient was doing. So you can see that leads to this amputation on the flow waveform. And that's the classic image that you're going to see whenever there's early cycle. So late and early. Rob?
Looks good.
All righty. So with that, this is just a brief, fast statement on late and early. Yes. I love it. Thank you, Miguel. So one of the questions, and Miguel has it here, is on strict terms, as he puts it, is the first example labeled as normal is also late cycle, but clinically there is no attempt from the patient to exhale. So is that okay? Am I right? And yes, you are right. Actually, this is part of that nomenclature that still needs to be dried out, in which, for example, in case number 1, in which there is a small amount of effort, and after that is a small amount of effort, essentially the breath becomes passive, you could say that this patient is over-assisted. So it's getting too much effort, so too much P-vent for the amount of PMOS that the patient generated. And that, if that is unintentional, then definitely that is over-assistance. But your point of saying, well, is it late because there's evidence of an increase in pressure or activation of the expiratory muscles is a valid one. Rob?
Yeah, like I said in the chat, anytime you have a preset inspiratory time, almost by definition, you're going to have a cycle desynchrony, except by the rare chance.
Right? That somebody says it nicely.
Yeah.
Very good. Good point, Miguel. As always, mastering these concepts. So here's the first example, and I actually had the chance to interact with Enrique now in Florida when we ran the SEVA course. He's one of the fellows at the University of South Florida in Tampa, and he sent me these images today, so you can see that they're fresh out of the oven, just right for us to discuss. So let's start with the tag. If you want to start writing what's the tag that you see for this mode, and you can see that it's up here. So what would be the tag? And I start seeing people put it in, and excellent, yeah, high quality recognition. So this is a common mode that people confuse with volume control. So kudos to everybody recognizing that this is a pressure control, and it's CMV, and it's A for adaptive. And that means that we're controlling the pressure, and we recognize that because the flow is not controlled. There's multiple changes in the size of that flow. It's mandatory. All the breaths are mandatory. And we know that even though they're triggered by the patient, they are cycled by the machine and or the ventilator. And that becomes evident with this process that we see here. So we'll talk more about that. And finally, the targeting scheme is adaptive, and it's challenging sometimes to see on these waveforms the targeting scheme in action, because you don't have enough breaths to determine that this is adaptive or if there's something else going on. But just by knowing that this is PRVC, you would know that it's adaptive, meaning that the inspiratory pressure is going to be adjusted to attempt to deliver the tidal volume that the caregiver put in. So it put 380. The machine is going to try to deliver that with the inspiratory pressure up and down to achieve that. Rob, comments?
No comments.
All righty. So from there, we go to the load. And so during inspiration, what do you see? PMOS, resistive, or elastic? Yeah, fabulous. So rapidly, your eyes recognized PMOS. Excellent job. And there's pretty active PMOS. I mean, normally, I always put in my mind how would passive would look, and if you paint passive, it would look like that. So everything that is on top is PMOS. It's activation of the inspiratory muscles, and then during expiration, we have a very rapid drop on the expiratory limb, and rapidly goes into it. And so it's hard for me to see it, but at least the initial parts of it would be consistent to me with somebody that is either very elastic load or is going into inhale rapidly. Rob?
Yeah, it's real hard to tell that one.
Yeah. So I would say elastic versus question mark. All right, so what's the PV discordance on this one? So let's start with the trigger. Normal, early, late, false, or failed. Circuit test was not done, it says here. So no. Okay, so what's the trigger here? Okay, normal. Good. So I'm seeing normal in several, and it's a pressure trigger. So for whatever reason, they decided to set a pressure trigger, and you know that because the change in color on this ventilator, and in several other ventilators, they also will put other markers, but in this one, we know that the change in color on the pressure waveform means that it's a pressure trigger. So this would be a pressure trigger, but it seems that it crosses the threshold rapidly, and there's not much time, and it starts pressurizing the system. So I think that this is normal. Rob, do you agree or disagree?
Yeah, you might argue that it's a little late, but I think I would just go with normal.
Yeah. But however, I mean, if you think about work of triggering for this patient and the initial breath, it's pretty high. So the patient is going down, and then suddenly the pressure, you can see how much it drops And it really doesn't pressurize. Even though this is pressure control, you would want to have the moment that it pressurizes essentially a curve that would look like this. So all of this area in this is what's being deformed by the high PMOS that the patient has. So the question during inspiration, is there assistance, over assistance, under assistance, and recognizing assistances? Yeah. And I love this because a lot of, so I'm hearing under assistance, and our classification, what we have said is, well, if the pressure drops below the baseline, then that's under assistance, definitely. But there is a period that, I mean, you can see how the pressure is coming down. There's a lot of effort. So there's a fair amount of work shifting. And we talked last week about how work shifting has a degree and probably a kind of a U-shaped work shifting. So if I put here 0 work shifting and here 100% work shifting or more than that, so meaning that it goes negative, that I mean, there's, if it's unintentional, then you would say that this is over assistance. And then if it's there's a range where there's work shifting, that you would call this under assistance. So really, I think that if you would look at this, you would say that there's severe work shifting and perhaps some under assistance. Rob, thoughts here?
Well, another way to think about this, and we do need some sort of metric for work shifting, a percent work shifting, but on the first breath where you drew in an expected passive inspiration,
Yeah.
and all the red area is active. So that's the volume that the patient's getting by the PMOS. And it looks like it's bigger than the volume he would have got just with a passive inspiration. So, it's like more than half of the tidal volume is being generated by PMOS. So I would call that, high level of work shifting.
Got a question, Eduardo. If the flow stops before the PIP, should we consider that the inspiratory pressure ends at the time of the flow, reaching 0, and the rest of the pressure waveform is caused by the opposition of the patient trying to exhale?
Are you talking about the cycling part?
The inspiratory part, when the flow goes to 0. So how do we know the pressure until where shifting is produced? Because you mark up to PIP, but it seems that the flow.
What's PAP? I'm sorry, Ariel, I don't understand PAP. Can you explain what you mean?
Okay, when trying to say that we got a PIP of 25, the flow.
Inspiratory pressure.
Yes, the inspiratory flow reaches 0 before the PIP. So I consider the pressure to see the wear shifting. If we draw a line from the inspiratory flow reaching 0 until we get to the pressure waveform, should be around at 16, I guess. When I'm trying to say that this is the wear shifting, the rest seems to be the opposition. I mean, the patient trying to exhale.
Yeah. So I mean, let's talk a little bit about the cycle, because that would help put this a little bit into perspective, Ariel. I see what you're saying now. So if we move into cycle, what you see is that there was flow, there was no flow during a period of time, correct? And so we would term this either normal, early, or late. So people are already putting there that this is a clear case of late. So the question here and the comment that you're making is that from this period of time, if we follow this line up here, right, all the way over here, all this pressure that you see over here is essentially not assisting the patient. Is even though there's pressure, there's no movement on volume, and so there's no work. It's just pressure that it's being imposed on the circuit because the patient is either relaxing the respiratory muscles or whatnot. Is that what you're trying to comment, Ariel?
Yes, but I was referring to the part that we can see the wear shifting should be from the beginning of the trigger up to that part you draw.
Yes,
that's what I'm trying to see.
Yeah, and actually this is a common item that you will see. And we have some graphs that demonstrate that when there is a lot of activity of the patient, like in this case, a lot of work, actually the inspiratory pressure that the ventilator is doing is this little shelf that you see over here. And the rest is the relaxation of the respiratory muscles or the active expiratory muscles. So when you put several breaths, and we have an example of this very nicely, in which you would still see all these peaks occurring, but that's the relaxation of the system. But the pressure keeps going down and down and down because the patient is doing all the effort. So in reality, the algorithm is trying to pressurize to this level, but then the system, the patient exhales and the pressure goes up. So without a doubt, all of this area that it's here, that's the amount of pressure that the system is giving to the patient. And the patient is doing as much of that. Does that make sense?
To keep in mind is that work shifting is reflected in the flow waveform. And when there's a period of zero flow, there's also a period of zero volume change. Yeah. If there's zero volume change, there can't be any change in work, right? It's only what's it called, isometric or isotonic work. There's no physical work happening.
So you would measure, and this would be important as we start defining this a little bit better, is that you would want to define exactly what's the period where the PMOS is occurring, the inspiratory PMOS. There's another question or comment here. Majority of pressure after a cycle is delivered against an exhaling patient. Yes. Was this recoil? Doesn't it? Yes. I mean, this could be absolutely recoil. When the patient exhales, I don't see any very clearly any PMOS, exhalation PMOS, so it may be just recoil. Is this high pressure with zero flow secondary to the relaxation of PMOS and recoil instead of yes, exactly, Mohammed. There's a lot of noise, as you can see, but that's what we think. So any other comments, Rob?
Nope.
So how would you treat this? So let me ask the team to enter into the chat. How would you deal with this? What if you had to choose your first action that you would do for these patients? What would that be?
Call Megan Hildegard.
Whoever is not muted, I think is Bosheri. I'm gonna mute you. Good. So one said, let's do an SAT. Is the patient ready to be weaned? Get rid of PRBC as the first step until we found the cause, liberate as the TI, and also choose an S targeting scheme instead of a switch to PC-CMVa. Yeah, so there's a fair amount of comments here. I mean, you're recognizing that you're controlling the comments go in two directions. The first one is what's the goal, and I love that you thought about that initially. So if your goal, because that will depend on how you're going to deal with this, right? If your goal is safety, you're going to behave one way, and if your goal is comfort, you're going to behave another way. And yeah, exactly, Ben Buster. So either of those goals. So the majority of you recognize, well, do we need to do an SAT or an SBT and get this patient off the ventilator? That's great. If you're thinking safety under this circumstance, you need to know what's the cause of this, and that may be an important step. Sometimes while you're trying to get there, you can change so there's temporary measures that you could do, and I agree, changing the patient to PC-CMVa would give you information, calm down the situation when you figure out what needs to be done. But this method is not achieving if you have a late cycle and you have severe under assistance for this patient. So very, very, very important to do that step and move from there to this. And just by changing to PC-CMVa as an alternative, the first thing that you're doing is that you are getting rid of the late cycle. So that will disappear rapidly. And the second one is that you can target or adjust your ventilator to achieve or decrease the amount of work shifting that you have. Rob, comments?
No, I would just summarize that by saying if the primary goal is comfort, and we're talking about synchrony here, then the fundamental problem is that the set inspiratory time doesn't match the neural inspiratory time. So simply get rid of the set inspiratory time.
Yeah. And actually, that's another important thing. That's why I think that sometimes choosing wisely here is that if you read this, you would say, well, work shifting, and then one of our rules is to treat first the first thing that you see. And then you would say, well, I'm going to increase the tidal volume, or I'm going to increase the support. But you have also late cycle there. So maintaining the eye time in a patient like this would be not a fair statement to do for this patient. All righty. I put an extra one. We have 7 minutes, and this is just like he sent me 2, and I thought that this one was so painful that I had to put it in because it was important. So I think that it speaks to a couple of the items. I presume this is a different patient. I could not tell just because the settings changed radically. But the tag, I'm gonna just accelerate that part because we already did that. It's the same mode. But I would ask the team, what do you think is the load? Elastic, PMOS, resistive? Yeah, so the teams are recognizing rapidly this is elastic, and this is an important one because you're gonna have different breaths, and some breaths may have PMOS, but others don't. And so if you come to see this one, it's a machine triggered breath or ventilator triggered breath, and then you see an exponential decay and no evidence of activity, and then during exhalation it seems to be passive too, and it returns to baseline very fast. So I think for all of you that read this as elastic, there's no doubt about it, but there is evidence of PMOS otherwise in other areas. So yeah, good job, Mohammed. That's exactly right. So there's peace, but there's anger at the same time. There's both occurring there. So let's talk about the trigger. And so we have different breaths here. We have, I'm not going to count this one as the first one. I'm going to count this one as the first one, the second one, the third one, and it's the fourth. And I'm going to ignore the one that is happening over here. So what's the trigger issue here? What's the main trigger problem that you have here? So the first one is not, it's passive, so we don't see any triggering, and there's no PMOS, evident PMOS afterwards. What about number 2? Normal trigger, early trigger? Yeah, and what about 3? And so remember, 4 is the result of 3, actually, I would say. So 3 is the early trigger that you guys have recognized. Excellent. So this is normal. This is this is normal, actually. If you see, there's a minimum gap here, a drop, but the crossover seems to be appropriate. So I would say that this is normal too. And this one over here, it's a machine triggered breath followed by PMOS. So this is definitely an early trigger. So I would say normal times 2 plus 1 early trigger. And this one over here is triggered normally also by the ventilator, but it's a double trigger pattern. And this is a classic. We've seen a lot of this in SEVA VentRounds. Early trigger is a classic cause of double triggering or multiple triggering. And then during inspiration, so on the first one, there's no activity. On the second one, there's some work shifting. And on the third one, there's more, but remember, when there's early trigger, you're always going to see some work shifting, so we don't count that one over here. And then the cycle, you can see is on this one, I mean, this is a setting, so it doesn't matter. But on number 2, the cycle, you can see over here, that is it's a late cycle. Good job. And then this one doesn't count. Actually, it would be an early cycle, what would occur on this patient. And then expiration, I think, is normal on all of them. So the rise angle seems to be the same. So it seems that the P rise time is not set as its maximum. Yes, now I understand what you're saying. So Ariel is commenting that the speed with which the pressure is rising is not very fast. So sometimes this is a button that gets touched a lot, which is the pressure rise time, and so it gets moved down so that there's not this little blip, which means nothing. And so, yeah, you're right, Ariel. It seems that it's delayed on the way that it goes through. Rob, comments?
Just real quick, notice that breath number 1 is passive and 3 is passive.
Yes.
The inspiratory pressure on 3 is less than number 1. That's because number 2 had an excessive tidal volume. And that just shows you how quickly the ventilator can respond with its adaptive targeting.
Oh, that's a great point.
Right?
Actually, but there's another item to recognize here, Rob, which I learned over at SECM this time, and it is that it turns out, and I don't know if this is the case over here, but I presume that it is, that the algorithm for PRBC, at least how it's up, this was a conversation that I had with Traeger, but I've seen this also on this one, is that the pressure that is going to be used for a machine trigger breath in PRBC. So if there's 2 breaths, if there's mandatory and there's passive breaths, the pressure that will go for a mandatory breath will be set by one algorithm using the PRBC, and for the spontaneous breath, even though it's mandatory, it's going to be a different pressure. So that's why from this one to this one, the pressure is higher, and I think that's what happens on this one. And we have seen this when we are on auto mode too, that you have a small breath and then a big one, and I think that's exactly what happens here. This breath is being commanded by this one, so this one set for the next mandatory. This one set it for this one. So this one, the breath number 1 commanded breath number 3 because they are mandatory, and breath number 2 commanded breath number 4 because they're patient triggered.
Well, why is this spontaneous or patient triggered breaths? Why are they higher in inspiratory pressure? Why is the separate algorithm? Why does it make the pressure higher than the mandatory breath?
That's a great question, and I do not. It's not always. Actually, there's times that it's the opposite. So I've seen both going ways, but I was talking. I had seen this, and we had thought about it, but as I was sitting in the Draeger, they were demonstrating me that their PRBC was different, or they call it autoflow, because of this, and I was like, I think I've seen this before. Ariel?
Yeah, on auto mode, every time I use PRBC to volume support, the first spontaneous breath start almost from a little bit more than PEEP and start gradually increasing. So to me, it means like the level of spontaneous pressure is not determined by the previous mandatory pressure level.
Yeah. So and this is easily managed on our simulator. We can prove this actually relatively easily. So good job, everybody. This was an interesting case of saying, well, the only thing that I would say is I was dealing with this patient in particular. It would be, again, the goal, and then probably decrease the rate on the patient. It seems that it's doing both at the same time. But all righty. If you want to send us images, that's the Twitter, that's Rob's and myself emails, please do it. We are actually, I realized that they have not uploaded all our other episodes, so we'll have 5 episodes loaded in the next days. So I'm sorry about that, but it was great seeing you, and greetings to all of University of Miami and Jackson Memorial, thank you for hosting us. Really was really fun. Rob, anything else besides stay well?
Peace and love.
Peace and love. All right. See you all. Bye-bye.